get started here. So I'm going to give a talk about the pathophysiology of obesity and its implications on treatment options. I have disclosures which are not relevant to this talk. When you see the next image, I want you to think about what the first word that comes into your mind. So if you can all look up at the screen and think about what word when you come to see this picture. I teach medical school, and years ago, my medical students wrote this down as their first thought when they saw that picture. And as you can see, it has quite disturbing words in it, and it shows us that we still hold judgment for those who have obesity. And so what we see here is essentially weight bias and stigma that occurs early in postgraduate medical education. Jeff Friedman, who his lab discovered leptin, said this, that people often reserve their harshest judgments for those conditions about which least is known. I think it's very telling, because when we see these pictures of people, a lot of the thought about how they are lazy, lacking self-control, non-compliant. You'll hear that a lot in obesity treatment, people not having adherence or not having compliance, or they're dishonest. They tell us what they're eating and we don't believe them. And we think about obesity as a character flaw or a lifestyle choice, as if people who have obesity would like to have obesity. And so we've focused our policies, our treatments on things like inactivity or poor diet, sugar-sweetened beverages, lifestyle, and behavior change has really been the hallmark of treatment options that are available for obesity. But we have to consider what lies beneath the surface in the individual who presents into us. So we talk about energy density of foods. We talk about genetics. There's 13 different syndromes of genetics which can cause obesity. Developmental behaviors and pathways at an early age increase one's risk of having obesity. The epigenetics, women who have obesity give birth to children who have an increased risk of developing obesity independent of their food intake. So what we've learned more about is other lifestyle factors. Sleep, for example, a lack of sleep or an altered circadian rhythm can lead to weight gain. Stress and other psychological factors can impact weight and weight gain, as well as hypothalamic dysfunction. Children who have brain tumors, if that tumor is in the area of the hypothalamus, when that tumor is removed, the hypothalamic pathways are disturbed and that person develops obesity. We've heard about insulin resistance, but there's also leptin resistance. Medications can cause obesity, changes in our microbiome or microbiota. But it's really probably many different factors that we see here that probably cause obesity. And it's not a character flaw or lifestyle choice. It actually is a dysfunction of a very highly regulated physiological system, and in fact, a disease. This action study, which I think is a very interesting paper that you all should read or at least pay attention to, was a survey study that surveyed providers and patients with obesity. And as you see, that providers, most people believe that obesity is a disease, and 72% of providers who were polled agreed that it was their responsibility to help that patient who has obesity. But as you see less clearly in the columns below, over half of them thought it was actually that they lacked time in their appointment to address obesity. A lot of providers thought that patients needed motivation to lose weight, and they didn't believe that the patient was interested in losing weight. So what you see in studies like this is that providers, us, still have a form of bias that contributes to inappropriate care of patients. Jeff Friedman also wrote this very eloquent personal narrative that I think you should pay a little bit attention to, because I think and I'll quote from it several times today. I think it's a very interesting perspective. And he says there can be no meaningful discussion of obesity until we resist the impulse to assign blame. And that's what really gets in front of us when we're trying to talk to our patients with obesity. We're judging them before we even begin the conversation. Dr. Crow mentioned this earlier, that over 10 years ago, obesity was declared a disease by the American Medical Association. We know that there's many different pathways that interact, that regulate our body weight. We have peripheral signals that I'm sure you've heard about, ghrelin, leptin, coming from ghrelin from the stomach, leptin from the adipocytes. But there's also central signals within the hypothalamus that drive weight regulation. And we see this both homeostatic and as well as hedonistic control. As you see, there's other hedonistic pathways that lead to the brain that control. But it's really within the hypothalamus, specifically the arcuate nucleus, that we see central regulation of body weight. And we know that there's a fine balance between our food intake, but what often isn't discussed is also our energy expenditure. So people who have Down syndrome actually have a lower energy expenditure. Women who go through menopause have a lower energy expenditure. So we have to think about how our body regulates weight before we even think about how to treat it. It's important to understand that our body fat, our fat cells, are very highly regulated, much like other parameters and physiological systems in our body. So if we take glucose, for example, we all understand and have learned about the regulation of glucose. And really, people who don't have diabetes, regardless of what they eat, we could all eat a bag of sugar right now in front of me, and your blood sugar levels, if you don't have diabetes, are not going to go over 125 or 26. They're going to stay very tightly regulated. And that's important to understand. What we really have in our bodies is a hypothalamic set point, which is actually the way our body regulates our body fat. So early studies done in the 1970s looked at rats, and really dispelled a lot of the popular notions that have tended to color thinking about the pathophysiological of weight. As you see here on the right, let's see if I have a pointer here. As you see on the right here, this is interesting, that they actually did a lesion of the hypothalamus, the lateral hypothalamus, and you see regardless of what it was given, eggnog or wet mash, which is a high carb load, you see that the rats that were in the control study and those who had the hypothalamic lesion responded the same way to food. Yet the ones who had the lesion were clearly at a different weight range. Down in the lower area, you see that also there's changes in the body weights of these rats. And so when we look later on in terms of how our body regulates itself with interventions, you see here the red lines are the control group and the blue lines are the lesioned rats. And you see again, their patterns mimic each other, but just at a lower range. When subject to a restricted diet, you see that these rats all lost weight and then regained weight. And I think it's important to understand is that the end weight you see here is actually higher than the initial weight after the diet or the restricted diet was given to the rat, which shows us that people, when they regain weight, might even go to a higher weight, which isn't actually abnormal. It's just fitting the natural curve of weight gain, as you see here. So those early studies allowed us to accept that there is this hypothalamic adiposity set point. And so when you reduce calories or increase physical activity, you see regulation come back to that point in terms of body weight. Also, if you overfeed a mouse or a human, you see that the energy expenditure goes up and you see regulation here. So really what we have is a weight range, or this weight set point. And that obviously can change over time. Medications can change that. Menopause can change that. Having pregnancy, delivering babies can change our set points over time. But still, it's important to understand and respect that there's a very strong regulation. So when we look at the regulation, we understand that the regulation comes from hormones like leptin. And you see, as we gain weight, our fat cells get bigger, and when we lose weight, our fat cells get smaller. We don't gain or lose fat cells, but within this regulation of leptin, and you can think of leptin like a gas gauge in a car. It tells our brain if we're empty or full. When we lose weight, our body is driven to increase food intake and decrease energy expenditure. So this regulation is very important, and it's just one pathway in the body that regulates body fat. As you see, when that gauge goes to full and people gain weight, you see people who have obesity have leptin resistance, and that can impact the inability to lose weight. Again, just one example of how the understanding of our pathophysiology and genetics drives treatment options. Again, the OB mouse was first discovered by Jeff Friedman's lab and studied, but also soon thereafter, a group of consanguineous families were discovered also to lack the gene of leptin. So they did not have the leptin gene, they did not make leptin, so their bodies and their brains felt that they were always on empty. So these individuals gained weight early on, and by the age of 4 or 5 were already 80 kilos. And you see here, the treatment option was easy, because if they lacked leptin and you give them leptin, they lose weight. In the United States, they had a competition called the Biggest Loser competition, and that was actually a group of individuals who had obesity were put in a special area, and they lived together, and they ate together, and they exercised together. They were given all the resources, and they were able to lose weight. And you see here on the left-hand side many of their weight trajectories. As you see on the left-hand side, one example was that they had lost weight. Danny Cahill down here was the winner. He was the winner in red, and he lost all this weight, and then he regained weight after 6 years later. And you see all but one person, Aaron, was the only person who actually continued to lose weight. The one in yellow actually got gastric bypass. And you see that when studied, that the correlation between their weight gain after 6 years correlated with their reduced metabolic rate. So this metabolic adaptation that occurs as our fat cells shrink when we lose weight was so strong in individuals that correlated with the degree of weight regain they had after the contest was over. So, but regardless of that, they still all lost about 12% of body weight. And there was a great variation of their body weight. But the important thing and the takeaway of this study was really that this wasn't the reality of obesity, of doing these highly restricted diets or increasing their physical activity to the point of abnormality. And we see what takes place is what clearly was discovered in Rudy Leibel's lab early on, showing that when forced to gain weight or forced to reduce weight, as they did in this experiment of about 18 individuals on a low-calorie diet, they showed that there was changes in the metabolic rate. So when we gain weight, our energy expenditure, our metabolism actually increases. But when we try to treat our patients and help them try to lose weight, we have to understand that their body might have some metabolic adaptation, and they're actually losing weight and actually fighting their own pathophysiology or physiology, as you see here, in those who lost 10 and 20% of their body weight had a clearly reduced metabolic rate of over 300 calories a day less than they did when they were at the previous weight. Simultaneously, what happens outside of leptin are some of our gut hormones changes. So the hunger hormone ghrelin that comes from the stomach primarily increases when we lose weight. And some of those satiety hormones that drives satiation in the hypothalamus actually decrease when we lose weight. So we see in the Sumithran study in Melbourne, Australia, 50 individuals who did not have diabetes were subject to a very low diet, a very low calorie diet, and actually lost about 14% of their body weight in the first 10 weeks. And then they were put on a low-calorie diet the rest of the year, and they were interested in understanding what happens to those hormones. And not surprisingly, what we see is ghrelin increases and some of those gut hormones decrease when the subjects were at a lower weight. So bottom line, it's very difficult for us to lose weight. And if you've ever done it yourself, I would suggest, if you have never done it, I think it would be a very good project to do, is actually put yourself on a low-calorie diet and see how you feel. Understand your patients, because eventually, like these little fat cells in the body, they're just waiting to come back. Back to Jeff Friedman's perspective, I think it's important to understand the extraordinary level of precision our bodies have when balancing the calories that we ingest. He says over the course of a decade, a typical person consumes approximately 10 million calories, generally with only a modest change in body weight. To accomplish this, the body and food intake must precisely match the energy output within 0.17% over that decade. So our bodies are finely tuned to control our body weight, despite all the calories that we eat. So 3 things I want you to take away from this talk. 1, listen to your patients. 2, understand and appreciate the heterogeneity of obesity and the variation of individuals who have obesity, their variation of a treatment, and also that one size does not fit all. It's very important, regardless of what your profession is, to listen to people. We do that in people regardless of their disease. But somehow we still have judgment when it comes to patients who have obesity. So I think it's important to understand your own internal bias. And there are tests out there that you can take, implicit association tests. One thing that I do with my patients in clinic is just understanding their story. And that can be done very easily, and tell them to draw on their graph of what their course of weight was or is over the course of their lifetime. That can give us a profound effect of understanding what has changed their body weight, and really helps us, both the patient and the provider, reflect on what's happened in the past to then set expectations moving forward. It's very important to understand this slide, again from the action study.
5 minutes, Dr. Butsch.
Thank you. That patients themselves come to us with a level of bias. Only 65% of patients who have obesity, over 3,000, actually believe that obesity was disease, and over 80% thought it was their responsibility to help themselves lose weight. You know, people, when coming and plateauing their weight over time after whatever the intervention is, patients are going to come to us thinking it's their fault. And it's our job as providers to tell them that it may not be their fault. It may be just some of the physiology I just told you. For the dietitians in the audience, some of the challenges when polled of registered dietitian nutritionists in the United States, they thought that the lack of adherence or the lack of willpower was a difficult aspect of their interaction with their patients. But I think it's important to understand what is willpower and what is adherence. So this is a study looking at 4 different diets: the Atkins, which is a low-carb diet; Zone, which is a balanced diet; Weight Watchers, which is a tracking of a healthy diet, and Ornish, which is a very low-fat diet, you see on the right side that there's no correlation between the body weight lost of all those 4 diets after 1 year. And what they showed on the right-hand side is that they asked those individuals in the study if they were adherent to their diet. And they showed that the more adherent on the scale of 1 to 10, the more effective the diet was. So the conclusion in this paper 15 years ago was that adherence is important to help people lose weight. But if we look at the data, look at the variability of the group who are on any of those diets. Does that correlate with adherence? Well, look at the 2 people who said on a plant-based diet, I was very adherent. They had 2 different weights. So I think we have to take that individual variation into account and really challenge ourselves as providers of what is adherence and what is biological variation. Because if we all hold our breaths underwater, I bet all of us will come up for air. And that is physiology, and that is what's going on in our patients who are trying to lose weight through restrictive diets. Appreciate the heterogeneity. We appreciate that there's different types of cancer, and for each different type of cancer, there's a different treatment. Therefore, we should understand the heterogeneity of obesity, and that those patients who come to us aren't just a BMI number, aren't just a certain scale weight number. They're probably a different type of obesity. And we should understand their risk profile and their quality of life and their ability to maintain a diet. And really maybe ask them about their genetic profile, if they've had obesity from a young age, which correlates with genetic form of obesity. If we take the apples and pears, which you all know about, we know that if you hold your weight more centrally and you're an apple shape, you have a higher metabolic risk. And if you're a pear shape, you have a less metabolic risk and more subcutaneous fat, etc. Geneticists have found a Kruppel-like factor 4, and if you express this, you're more likely to have distribution centrally, and rather if you don't express it. So clearly, when we look at apples and pears, there's that differentiation. But I want you to appreciate that there's a lot of different apples out there. There's some of your patients don't ever feel full, and that may be a biological driver. There's people who respond to certain macronutrient diets. Some people lose weight on a low-carb diet, some people don't. Some people have a BMI of 30 and have every single disease known to man, whereas some patients of mine have had a BMI of 90 and have no metabolic disease. There's probably a different set of pairs out there too. People with different sleep patterns, people with different taste preferences. And it's our jobs as clinicians to actually go out there and ask them these questions so we can help them appreciate the diversity of their disease. Because when you look at studies, whether it's a diet, you see the heterogeneity within the treatment. Some people gain weight and some people lose weight. It could be exercise. It could be surgery. People are going to respond differently, and we cannot judge them based on their response. So lastly, I think it's important to understand that it's not a one-size-fits-all. You can't just give someone a low-calorie diet and expect them to lose weight. That's why, again, I think we should all do that as providers. You know, telling someone to lose weight and exercise more is like telling someone with depression just to cheer up. We don't do that with depression, yet we do that with obesity. We don't even have guidelines. We have anti-guidelines that tell us what we can't do. We can't give a medication if the BMI doesn't match this number. We can't do surgery if it doesn't match that number. We followed a treatment paradigm which is focused solely on changing someone's behavior, leaving just the wee bit for pharmacotherapy as surgery. But we have to shift this paradigm, moving away from eating less and moving more. And instead of focusing, as we've done in the past, on behavior change and appetite suppression and restriction and malabsorption, which all were based on thinking that the goal was to reduce calories in or maximize calories out, we focused on the wrong thing. We focused on the ability to be thin and focused on behavioral change. But we know too much now about the pathophysiology of the body, and we should really change that goal to change the set point where behavioral interventions, medications, and surgery work together to individualize treatment. And the goal is to decrease that set point regardless of what the treatment is, whether it's surgery or medications or a certain diet. Because we know that the treatments that are available work in many different areas, many different pathways. And for some people, it may be that's the pathway that you have to treat. But we should appreciate for some people that may not be the pathway. And we should continue to treat the obesity. Whether it's surgery, whether it's giving medications after surgery, etc. And was said before that this is really a team approach, is an interdisciplinary care, and that is only reflective on the fact that this is a complex biology. So obesity is not just one disease, and it's important to appreciate that the response to treatment varies, but more importantly, to treat it seriously like we do other diseases. And so we shouldn't really call it obesity because it's not one disease. Maybe we should call it the obesities. So in the words of Jeff Friedman, again, to end the talk, fighting is a difficult battle, and it's a battle against biology. So the key principle is to understand that our own bias can lead to suboptimal care, that this is a complex biology, and we have to understand that it's not approached in the same fashion as other diseases that we take care of. There's a wide heterogeneity of this disease, and it has a very broad variation in how people respond to individual treatments. But the goal really is to reduce that fat mass set point and really focus our strategies on individualizing treatment. Thank you again for allowing me to present today. Thank you, Jamal.